this one is in the pocket, and this one I think is. Wait.
Bueno, seguimos en el bloque de diagnóstico y
¿Cómo es esto?
después de haber hablado de la imagen y la anatomía patológica que hemos tenido que adelantar, vamos a hablar ahora de los biomarcadores. En primer lugar, el doctor Bjartell de Malmo nos va a hablar del 4K.
It's okay. Oh yeah, perfect.
Today, yes.
Yeah, today.
Is this one? I think so. This is it.
That's it.
You have this one if you need it.
Does it work?
The light.
I think it's run out of battery. Don't need it.
Yeah. You got it, speaker.
Okay. Oh, it is. Okay. That one. Okay, thank you very much. It's a great pleasure to be here. I would like to thank for the kind invitation by the organizers. And this far we've been talking a lot about imaging. I love images. I really love it. I also love pathologists and radiologists, and it's very, very important that we work close together. I also like clinical chemists and researchers who have developed tests that I would like to discuss with you now. The 4-calligram panel, but not only the 4-calligram panel, but also a lot about PSA and some other markers. So these are my disclosures. So this is the agenda. I would like to discuss a little bit more in general about biomarkers, and then more about the PSA variant, the new PSA tests, a little bit about strategies to find new markers. So there is now, today, since 1-2 years, a lot of support to guide you how to develop the best biomarkers. And you can find a lot on the FDA website, and they also have written a book about where they describe the important step, how you should develop and evaluate the biomarker. So it's not easy, it's a long way to go. First you need a robust test. You need first you evaluate it to single center and then multi-center studies. You need an external validation with different cohorts. You need large prospective studies, and then finally commercialization and approval. So that's a long way to go. And before that, you need to publish a lot of studies on your biomarkers. You can also find information what to put in the publications. Okay, speak up.
Speak a little bit louder.
Okay, sorry. So this is how you should report your biomarker studies. I think it's very useful to look at this publication before you go ahead and publish your markers. So how do we know if a biomarker is good or not good, if it's useful in a clinical setting? Well, we always put together sensitivity and specificity and then create this ROC curve. And if it's the area under the curve is 0.5 or less, it's absolutely no use in a clinical setting. The higher the graph will go up and the larger area under the curve, the better the biomarker is. So we're often talking about like 0.7, 0.8 to describe the performance, how good the biomarker is. And this is also true for a single PSA test. So how can we predict prostate cancer using biomarkers? Well, we know that PSA is a very well-established biomarker. It was discovered in 1979, but still is not, we don't always know how to use it. But it certainly has revolutionized how we diagnose prostate cancer today. There are many examples of that. It's an independent biomarker, and it's better than digital rectal examination. That's no doubt about that. And if you look at this is from the European EAU guidelines, you can clearly see that at different PSA levels, and they're all low levels here, you see the risk of prostate cancer at these different levels, and you see here a risk of more significant and harmful prostate cancer. But even at very low PSA values, you will find a certain risk of finding a prostate cancer, which often may be indolent, of course. So what else can we do with PSA? Well, we can compare different PSA values over time. We can look at the doubling time, the velocity, the different way to express it. But in the diagnostic setting, it doesn't really help us very much. It's a completely different situation when you monitor a patient for recurrent disease or after treatment. So there's a lot more to say about PSA. 30 million PSA tests in the US every year. Over 1 million biopsies performed annually. And you see, we have a serious problem with overdiagnosis and overtreatment. 75% of the biopsies we have a low-grade, what we can call indolent cancer. So here's the problem that was very nicely reviewed by Professor Alcaraz previously. So what happened with the PSA testing then? Well, 2012, an institute controlled by the government in the United States said that you should not do this PSA testing as before. You should stop doing it this way. So, because this was based on the results, especially from the American screening study, even though the European showed some survival benefit. So what happened? Well, there are now a few papers out describing the effect of stopping PSA testing. Well, there was in this study published showed that there was a 28% decrease in incident diagnosis of prostate cancer a few years after the recommendation not to be so active in PSA testing in the United States. But it's more a problem that now we find more advanced cancers, more high-grade cancer, because from this study from a big center, MD Anderson, they show that patients coming to them now have generally a higher PSA level, more severe cancers. So we need to understand better the effect of not doing PSA tests as before. And the question still remains how to identify the cancers we would like to find. This is another interesting publication showing that metastatic prostate cancer actually have increased the last few years, and also the incidence of prostate cancer in younger men, age 55 to 69. So we don't know how to handle the PSA testing in the future. So we need better markers, and there are many examples of why we need better markers. This is an opinion paper by Valentine Carter from Johns Hopkins. He put together here a list of the active surveillance studies showing that between 24 and 40% of the patients needed treatment within 5 years. So we are finding a lot of prostate cancers. Some of them we believe are not very harmful, but a lot of them need treatment within a few years. So we are not picking up and discriminating very well between harmful and harmless cancer with the PSA-based system we have today. So we all know this dilemma, which is of course described now with the PROTECT study, where about 50% of the patients needed treatment after within 10 years. And this was not only active surveillance patients. This group is now more in detail being studied. And the mortality, deaths from prostate cancer in treated groups with surgery and radiation therapy, extremely few patients die within 10 years. And it can be discussed a lot how to interpret this. So what we need to do is to identify this group better. Obviously, a lot in this group needed treatment from the beginning. And especially here, we also know from this study that patients who did not receive immediate treatment, they developed more metastases and there was some death in prostate cancer, significantly more compared to the treatment groups. So PSA is causing us a dilemma. What to do? Well, we need better PSA tests, and there has been a lot of work in developing better PSA tests for many years now. We have a lot of different molecular forms of PSA. We have pro forms, we have free forms, we have protein-bound forms in the blood test. Prostate Health Index test measures 3 different forms of PSA. The 4-calcium panel measures 2 of them, and also intact PSA and HK2, which is a protein very similar to PSA. The Stockholm 3 model measures the same as the calcium panel, but also MSMB, MIC1, and a genomic test with 232 SNPs. So, which one is the best? Well, what I would like to say, the good thing about the studies on these is the studies are designed to identify aggressive cancers, but in this case defined as Gleason score 7 or more, which is indeed a mixed group. Unfortunately, a lot of studies are based, as very good point made by Hashim before here, that a lot of studies and biomarkers are made when we made a 16th biopsies. These cohorts are not how we treat the patient today. So the 4-calcium panel, which is commercially available as the 4K score, it's about $300. It was launched here in Spain about 2 years ago. And it measures different forms of PSA, but it also put together the age of the patient, digital rectal examination finding, and if there was a previously negative biopsy. You get a score, and the score is how many % risk do you have to find Gleason 7 or more cancer if you take a biopsy. So then it's up to the doctor and the patient to how to handle the risk score. What's a reasonable level to perform biopsy or an MRI, or what to do? I would like to say that the 4-calcium panel has been studied more than any of the other tests that I mentioned, the PSA reflex test. It has been studied in retrospective material, large material, also in prospective studies. This is an example of a large cohort from one of 11,000 patients in where they were invited at age of 45 to 50 to give blood tests. Many years later, we knew that many of these men developed prostate cancer, so we'll have a lot of information about them. And in this study that Vickers put together, if the patient has a PSA level of 3 or more, and if the calcium panel indicates that this is not a cancer, then you can be quite safe and avoid a biopsy. Of course, it's not 100%. This is another example of a large cohort that has been studied. It's from the other end of Sweden, the northern part, up in Norrbotten, put together by Per Statin and Hans Lilja, who developed, who's now in MSKCC since more than 10 years ago. He was the one who developed this 4-calcium test. In this study, more than 12,500 men were followed for more than 15 years. So these studies are huge, they are quite unique, and the material is very robust. And when they then developed blood tests were taken at 50 or 60 years, then many years later, they developed prostate cancer. So again, it showed that the 4K score is a reliable test to identify aggressive cancers. Not so they looked at aggressive cancers here. This is to illustrate how the 4-calcium test performed if you looked at screening cohorts in prostate cancer. This is different countries in the European screening test for prostate cancer, screening study for prostate cancer, where you find a pretty good area under the curve to predict aggressive prostate cancer in biopsy. So there's a quite good discrimination for high-grade prostate cancer in all the branches of the screening study. So this is a list of studies this far on the four-calcram panel, and one of them is also here a prospective study. So there's a lot of indications, and we can also perhaps talk about evidence that this test may save biopsies. So where I work in Malmö, there we have been using %free PSA for many years because Hans Lilja, he was working there and he developed the test. So we have looked at not only total PSA but also %free PSA when we make a decision to make a biopsy of the patient or not. So we were kind of biased, and then the question was, would the four-calcram panel adding 2 more proteins help us in that case? Well, in fact it did. So we collected a cohort of almost 750 patients, took blood before the first time biopsy, and if we added the panel to the PSA and free PSA value, we could detect 94% of cancers and only 6.2% of the high-grade cancer were missed using the full panel. And we could reduce the number of biopsies by 24%, which is considerable. So also in this setting where we had experience of using free PSA before, we could find the benefit of using the calcram panel. And now recently, well, it's not out yet, but it will be published next month in Journal of Urologia. Andrew Vickers, he put together a study where we looked at 8 different cohorts, and the question was, how will this four-calcram panel work if you have a PSA value outside of the gray zone, or if you have a positive digital examination? Is there any reason to use this PSA reflex test in that setting? Well, in fact it is, because it also performed very well in that setting to predict Gleason 7B, I mean 4+3 cancers. So, and area under the curve was 0.84 compared to 0.69 without the four-calcram panel for a patient with PSA 10 to 25, and if you have a positive DRE, it was almost as good. So in both cases, it seemed like this test can be useful. So yeah, and here you show the different 8 cohorts, and here are under the curves. And it also made a decision curve analysis and an estimation of how many biopsies you can save. And you can save more than 20% of biopsies also in this group, where you have more suspicion, higher suspicion of finding a prostate cancer. So, but if you actually need to take one step further to add the blood test to the prediction model, the risk calculator. And it has also been done and shown that it improves the performance. The same was done here in this publication, also for the urine test. So the Stockholm 3 study has been highlighted a lot since its publication almost a year and a half ago in Lancet Oncology. In only a few years' time, 145 men were invited, and they were between 50 and 69 to have a PSA test. And almost 5,000 biopsies are now available in this cohort. So the Stockholm 3 model was very similar to the four-calcram panel, addition of 2 more protein, and also the SNP, the Shipper SNP test, and like the four-calcram panel, also age and family history and previous biopsy. So it again showed about similar performance, but the area under the curve was not as good as for the calcram panel, but it's not really comparable because it's not exactly the same cohort. But again, it was shown that you can reduce the number of biopsies a lot, up to 44% in one case here. So how should we take this further? Well, there was a very interesting position paper by Sigrid Karlsson, Michael Tan, how we should use it. And they said that you should either not do PSA testing at all, or you should do better PSA testing that you do today. And in Stockholm 3 model, it may not take us that much further because it's a little bit unclear how much the genetic test actually adds to this compared to the 4-calorie compound. So what's in our guidelines then? Well, I can tell you that these PSA reflex tests, they are already in our guidelines. This is the European guidelines where they mention the 4-calorie and prostate health index test. And this is in men, PSA 2 to 10. You can either use a risk calculator or one of these new tests or the urine test or imaging. So, but the level of evidence is not very strong. NCCN guidelines, they talk about PSA testing it from age 45, which is very strange because the recommendation in the United States by the government is different. So, but they also talk about free PSA, 5 test, 4K score, etc. So, and they also talk about genetic test here. So, new strategies to develop better biomarkers. Well, it would be nice to make kind of screening test based on SNP analysis to target the whole population and identify high-risk groups. Well, if so, well, there are many publications on this. The most promising markers are actually now, if you look at the BRCAs, like in breast cancer or ovarian cancer, it seems to be very important. And in this study, the impact study, there was a difference between 1.6 and 3.3% in the control group or patients carrying the BRCA2 mutations in having prostate cancer. So there are something about the BRCA2 that may also be important in prostate cancer. And it was further emphasized in this recent study in New England Journal of Medicine by Peter Nelson and a big group of collaborators from different countries, where they looked at, put together 20 DNA repair genes and looked at the mutation. One interesting finding was that mutations in DNA repair genes was not well correlated to family history of prostate cancer, which was a little bit unexpected. But on the other hand, when they looked at, here you have 7 different cohorts, they found, although there was a variation, but on the average about 10 to 15% risk of having that men with advanced aggressive prostate cancer had these mutations compared to men with localized prostate cancer. So perhaps you can screen and identify man risk of having an aggressive prostate cancer versus a non-aggressive prostate cancer by looking at the panel of DNA repair genes. So, do we have any commercial available genetic tests this far? Well, if we talk about the diagnostic setting, there is one test to confirm MDX, which is designed to reduce the number of repeat biopsies, and it's based on epigenomics, and they look at DNA hypermethylation in this test. Still need more confirmation studies and validation studies. The other tests here, Oncotype Prolaris Decipher, are more based on when you have biopsies with cancer in or you have the whole prostate. And they are also used a lot now in the United States, perhaps not that much in Europe, but they can give some information, especially the Decipher tests have been published several times the last few years now. They can predict, they are more prognostic tests. So in conclusion, I think we can all agree that a single biomarker is not good enough today. We should go for some kind of multiplexing. The clinical pathological characteristics should always be put together with a biomarker. PSA reflex tests, they are now recommended in our guidelines. They have been studied a lot, so we have a lot of information about them. Today, we don't have that much indication or evidence for start using SNP test, genetic test to screen for, but perhaps these DNA repair mechanism genes, they are the most promising today. Genetic expression patterns in prostate cancer, they need more validation, much more validation, like we have for the PSA reflex test. And also, which I will not go into detail now, is of course that if we look at Gleason 3 and Gleason 4, there may be very different behavior. The phenotype will be different. You can look at P10 expression, P10 mutations in a cell. Yeah, I mean, it's not that easy as Gleason 3 is Gleason 3, Gleason 4 is Gleason 4. So, how do we handle a patient today? Well, this is how we do. We take a PSA, we take a trust biopsy, and we try to identify potentially harmful cancers. We can add a PSA reflex test here. We can add MRI, and we also do that today. We can do it early, before biopsy. We can do it after biopsy. And so PSA is absolutely not good enough today. We need more data on the PSA reflex test in this setting, but also in active surveillance setting. And we need to clarify the role of how we should use MRI and also PET-CT, which may be interesting in this setting. So this picture was shown before. The incidence of prostate cancer dropped after PSA introduction, that we don't detect that many metastatic cases, but it has actually started to increase. But the problem with the biomarkers we have is that there are different ways to look at prostate cancer. 3 different paradigms here. The first paradigm tells us that prostate cancer starts in the prostate, it goes to the lymph node, so that makes it quite simple. The next paradigm shows that it's already very early a systematic disease, which may explain that we can see PSA recurrences after 5, 10, 15 years. Or, this is even worse, the last paradigm here, the helmet paradigm, that there are different ways from cancer cells to spread, like from one metastasis to another, and it may be a much more complex situation that we believe. So, unfortunately, it makes it so much more difficult to develop a biomarker that fits everywhere. So, it's a little bit disappointing, but there's still more to do, and I'm going to end up here. Thank you so much.
Dejaremos, como en la mesa anterior, las preguntas para el final. Por lo tanto, invitamos al doctor Rubio para que nos hable de la detección del cáncer de próstata de alto riesgo mediante marcadores urinarios y el grupo del Instituto Valenciano